Yo, yo, yo. Hey, guys, welcome back to another awesome edition of the Best Practices Show podcast. Our goal is to find the best thinkers, to share some information, some frameworks to help you improve your practice and your life. And I have a regular guest back today. He's one of the rock stars in dentistry, Dr. Drew McDonald. And he examines the question, am I over-treating patients? It's very thought-provoking. So please listen up. I hope you guys enjoy it, and we'll see you soon. Hey guys, welcome back to the Best Practices Show podcast. The cool thing about my job is I get to interview the rock stars in the world of dentistry who are so willing to help and give us some great information to help us improve our practice and our life. And I have a regular, recurring rock star back today, Dr. Drew McDonald, who is an awesome thinker and even better human being. And today we're going to be talking about the concept of, am I over-treating my patient? Drew, thanks for being back, brother. I appreciate you.
It's always a pleasure to be back. It's been too long, Kirk. We got to do this more often here. But happy to be here, and this will be a fun one today.
Well, even though you've moved, I can still stalk you and track you down and make sure you come back on the show. But give us a little background. Now, I always like to start here. Even though you've been a regular guest, I want you to give people a little background on who you are. You've recently moved. You have a new location, and then we can talk about the why behind what we're going to be talking about. So
a little bit about me. I've shared this a couple times, but I think it's worth hearing for the younger people who are trying to get into dental school, trying to do whatever's next. I am somebody who has failed a lot. I learned in baseball. I grew up playing baseball my entire life, or until I couldn't anymore. But in baseball, you fail 8 times out of 10 and or 7 times out of 10 and you're a Hall of Famer. And so what I learned from my baseball days is that you get up, you be disciplined, you put it back on, and you dust yourself off and go, because the next time you're going to be successful. Or if you have that resiliency in you and you can just go and do it and be disciplined, good things are going to happen. So in dentistry, I feel like that happens to us every day. We don't have the best day. We don't put, brackets come off, an expander comes off on a kid, and you sit there and beat yourself up as an orthodontist. But if we have that resiliency, we're going to be better. And mentally tough, orthodontists or dentists are really what we can be and provide better for our patients. So yeah. I'm someone who failed a lot, and I've learned a lot from it.
Well, you failed forward. I don't think you've ever failed, but watching you've just transitioned your practice to Florida and your family, and you guys are loving that. And now, you have a pretty cool focus for the future. So, you're not just an orthodontist. You're a little bit bigger than that. You're a humble guy. Tell everybody what you're up to. What's on the road ahead for you?
Yeah, a big part of why I'm here in Florida now is so much of the unique focus of my practice. I am very interceptive on TMJ and airway issues and growth and development. That is a huge focus of mine as an orthodontist. I know traditionally as orthodontists, we are looked at as the people who move the teeth and put them in the place that makes them look pretty. Well, for me, my focus is foundational. And at the end of, or what I mean by that is that if we get the teeth in the wrong place or make the smile look pretty, but if we set the jaws where the jaw joints aren't functional, or if we don't help the patient breathe better by what we do, then we miss an opportunity. And as orthodontists, we actually have the biggest opportunity, if we are seeing things early, to really right the ship in so many patients' lives. We have, the capabilities now with technology and imaging with CBCT that's much more frequent in everyone's office, MRIs, which we're going to talk about a little bit today. And these tools can really help us see the foundational issues of the airway, the TMJ, the growth and development of our patients, the even neck issues on some, and talk about how do we right the ship and get these patients healthy. And oh, by the way, we can make their smile look great, but if we land the plane with the smile in the right place with respect to the joints, the airway, the growth and development of this patient, we can do so much better of a service for them. And so that's who I am. That's what I do. And out here in Florida, I do have the opportunity to work with one of the best, or not one of the best, the best, Dr. Brian Shaw, who is a TMJ and airway-focused oral maxillofacial surgeon. So I'm going to transition now, because me working with a surgeon means I'm working with a lot of adults that are in stage problems. They have severe airway issues. They are living on their CPAP. They have not slept well in years. They have severe TMJ issues. They're in pain, 9 out of 10 pain. They did not have to get here. They didn't have to get here at all. And they very often have had people fail them multiple times in diagnostics on their way to getting to Dr. Shaw's office. So he and I work together because if a patient has such severe jaw joint issues that they require surgery, then they often have bad bites. And we'll talk about that today with some evidence as to why it's so important to image patients early, why it's so important to intercept these problems when we first see them as kids. And ultimately, they don't have to become patients that see Brian Shaw, that we can intercept the jaw joint issues as early as we see them and set these patients on a better life, not one that puts them in pain, discomfort, dysfunction, and puts them on a surgical path. We can totally pick these things up if we know how to diagnose.
Yeah. And one of the things I love about you being a great educator is you're always pushing the envelope. And you'll continue to do so because it flies in the face of sometimes conventional wisdom, or maybe the way we've thought about in the past. And before we hit the go button, you're like, I want to talk about a few things. One of the subjects that keeps coming up is, am I over-treating my patients? Tell us the why. Give us the big picture on this question.
Yeah, I wanted to specifically talk about this because in orthodontics right now, there is a lot of progress happening. Good things. We are learning so much about how especially the airway can be affected by what we do, how we can help patients breathe better through their nose, how we can help growth and development, and when we should be actually approaching these issues, which is when kids are young and growing. We also are having so many advancements on our understanding of jaw joints and growth. That's the other big thing. And so for me, as part of my standard diagnosis as an orthodontist, I have to look at joints, and I have to look at it in 3D. I have to look at their airway. We have to have sleep screening studies as well. These are all parts of the standard diagnosis in what I feel is the future of orthodontic practice. We are not just looking at white things in someone's mouth anymore. And ultimately, the big reason why I'm bringing up, am I over-treating, is because we've had, sadly, a few setbacks in recent publication that are trying to attack this way of thinking, the progressive, foundational way of thinking. And one of them specifically I want to talk about, which was a very recent ADA huddle email that came out to all the dentists who are part of the ADA, was a JADA study that looked at, specifically image-based diagnosis. And basically, it would, if you're just using the imaging alone and setting up plans orthodontically that might involve surgery, that they're basically, this article called out orthodontists and saying that is wrong. That we should not be looking at joints in this way. We should not be discovering these issues for patients, because ultimately we're overstepping what we shouldn't be. And ultimately, for me, again, I don't feel like I'm overstepping whenever I am diagnosing my patient. And you've said it, we've talked about it before, but there might be many different ways to do treatment, but the diagnosis is the diagnosis. That's the black and white of this patient in front of you. And overwhelmingly, whenever I do my imaging studies, my CBCTs, my MRIs on patients, those things dictate treatment direction. If I stumble upon a nasal airway issue on a young patient, I'm thinking that is a reason that I need to expand this patient and help them open up their volume and be able to breathe better. If I stumble upon a jaw joint issue early in life on a young child, then I need to be able to, one, manage that, or two, if it's severe enough that it involves trying to reattach the disc that is displaced, or potentially doing any other type of surgical intervention to intercept this issue rather than be reactive to it later, then no, we are certainly doing our job. We're not overstepping our bounds. We are diagnosing the problems that are putting patients in our chairs. And so you and I have talked about this a lot. The biggest issue in orthodontics right now is that sometimes we hide behind a lot of these publications that have told us it's okay not to look. And this most recent publication in JADA really kind of irked me because it was telling patients, hey, you don't need to have an MRI. You don't need to have these other images because it shouldn't change what's being done, because you shouldn't be ever talking about surgical intervention because that's outside of what that's outside of our norms of what dentistry should be looking at. So, that article specifically kind of killed me, and especially because I utilize the imaging. I utilize hard diagnostics with numbers, images on every patient. And if we're going to try and say that is not a way to practice and that it's overstepping, then I disagree. I completely disagree, because we can do so much better for our patients if we're able to truly diagnose their problems.
Yeah, and I can say this about you wholeheartedly. I mean, further investigation on any of this, your motive for imaging is never money. It's really an understanding, and you're on the forefront of education. Imaging has also come a long way, so now we're learning even more. Can you just talk about the progression of imaging just in your time of being in practice and how important that is to orthodontics?
Yeah, absolutely. And sadly, I think this is what a lot of residents come out of school with, which is that you're taught in orthodontic residency and really in traditional orthodontic literature that a lateral ceph is the gold standard of what you should have. That's a two-dimensional image. And even in my residency, it was rare, but we could take a frontal ceph, which was a two-dimensional picture from the front of the patient, and really all that showed us was asymmetries of growth. And so a two-dimensional lateral ceph and a frontal ceph along with a pano has really been the standard of care in imaging and orthodontics for a while. Well, a lot of the reason that was is that we looked at the newer imaging technologies coming out, CBCT, and saying that's too much radiation. Why would I do that if all I need is a lateral ceph or even a frontal and a pano to tell me the same thing? Well, again, lateral cephs, what they tell us is how's the patient growing in a forward direction? What's the angulation of their two teeth in the midline? What a CBCT tells us is this is a three-dimensional patient. What's going on one side of the face versus the other? What's going on one condyle versus the other side? What is happening in their nose? What is happening with teeth in three-dimensional space, not just a two-dimensional picture that is not representative of the patient in my chair. So again, back to why I think a lot of hesitancy was surrounding CBCTs, it was the radiation factor. And the early machines had a lot higher radiation. That's pretty well known. But the newer machines and the ones that I use in my practice, they have very low dose radiation that's very safe for patients. And so for me, what I say is, if I'm only working in a two-dimensional space, I feel like I'm underdiagnosing my patient. I'm not seeing the true reasons why the patient's in my chair, which, back to previous podcasts, patients with airway issues are well known to have maxillary growth and development issues. Patients with jaw joint issues have tremendous mandibular growth issues. The condyle doesn't grow properly. When the joint's injured early in life, we have class 2 bites. We have asymmetric bites. So if patients have airway issues, joint issues, tongue and muscle functional issues that we diagnose, they affect this patient's growth. They affect their quality of life. And orthodontically, we have the ability to help right the ship on a lot of these patients. We can help expand the maxilla, help these patients get their jaw growth back on track if we do it early enough. Sadly, whenever we see adults, we have to use much more invasive expanders. The custom Marpies are great. I utilize those all the time in my practice, but it is a big deal to get one of those in. Yeah. It's, I had a patient last week that I placed one in. I had a call over the weekend. She's just in discomfort. That's pretty typical, but I wish I would have seen that patient when she was 4 rather than 40. And that's really what I want to get to is it's not over-diagnosing. It's not over-treatment. If we are seeing an issue, we need to tackle it right then and be able to, intercept and create, get growth and everything where it should be, but also create a better life for these patients as soon as possible rather than wait until the end stage has expressed itself.
Right. And go back to that. You mentioned this a couple times, the early airway interception. That's also a hot topic in dentistry. Give us some perspective on that. If somebody's not part of that conversation or watching that conversation, what does that mean?
Yeah. So a lot of, the most recent, the last few years, I should say, me and my personal practice, I have really begun seeing, kids 3, 4, 5, and 6. Never would have thought I would say that ever whenever I came out of residency. But I see kids at that age that have terrible sleep. They have terrible growth and development. I've seen one of the worst malocclusions I've ever seen was actually on a 3-year-old. She had a cross bite, anterior open bite, could not move her jaw. She was not syndromic. She could not breathe. And we were already seeing the growth and development issues on these patients. So sadly, people at the forefront of this, get thrown underneath the bus on this, saying that we are overtreating these little kids by jumping in early and helping them to breathe better, helping to get growth and development back on track. When the science really is here saying that when we expand, we increase the nasal air volume. At age 4, 5, and 6, it's a whole lot easier to get skeletal expansion than it is when the patient gets older and their maxillary sutures become more intertwined, and it becomes much more forceful to do the expansion on the older kids. So again, it's a different lens when we're talking about treatment for a different cause. If we're treating to help someone breathe better, sleep better, have a better quality of life, then yes, we need to jump in as soon as the problem's there. And a lot of the time, the issue is there on a 3, 4, 5-year-old kid, and it only gets worse as the kid gets older. As they become 7, 8, and 9, which is our typical time that we orthodontists say early intervention. If a patient sees me at 9 years old, sadly, I feel like, man, we missed a lot already. And back to our traditional understanding of growth, by age 5, 85% of the maxillary growth is done. By age 5, about 85% of the mandibular growth is done too, and the ramus heights are about 70% of the way done by age 5 as well. That is really an unfortunate thing if we wait until a patient's 9, 10, 11, or 12 years old, even when we traditionally thought ortho was, let's wait till all the baby teeth are out. Let's wait until all the permanent teeth have erupted. Well, that patient's done growing. Even if they've got a little bit of a growth spurt, that puberty growth spurt to happen, we've missed out on it at least 85 or so percent, if not 90, if not 95% of growth if we wait until that side. So again, am I overtreating by jumping in early? No. I feel like we as orthodontists should feel good about jumping in and helping when the patients are the most able to be expanded, to help manipulate growth. We are all orthodontic specialists and dental facial orthopedics specialists. That is part of our title as orthodontists. And I think we forget about that dental facial orthopedic side of things, unfortunately, and we just focus on the orthodontic tooth alignment. So again, back to controversy here, I think there shouldn't be any controversy about this. We know how to expand. We know how to apply the tools that we're taught. We need to just do it at the right time with the right information driving us. And that's where the imaging can help us understand what are we trying to achieve and where are we trying to go and why.
Yeah. Well, I'm a little bit older than you, so I can help you with this one. Like, very rarely do well-behaved people in this profession, or many are, celebrated, or there's always going to be a little controversy when you're challenging what we know, and I think you're on the right path. Can you speak to this, though? I mean, what we're learning about airway and dentistry, and even the term orthodontics. People say, I'm an orthodontist. And I'm like, okay, well, what does that mean? Because now you can really pick different segments. I'm throwing like a big hot mess at you, and I want you to decode this. I also think, this is my personal opinion, one of the biggest challenges in dentistry right now is the amount of information. Anyone can go anywhere and say whatever they want, and that's good, and it's also bad. So I think we're always going to have a little controversy, don't you think, on what we're learning, and as we challenge the status quo of, like, even children breathing, which is a hot subject. So speak to that.
Yeah, well, you mentioned it. Orthodontics is a big umbrella. And I want to start here because what I feel like our job really is we are the gatekeeper to so many different conversations for our patients. As I talked about, I feel like my biggest job as an orthodontist is to understand why this patient's in my chair. And so back to the common things that create an orthodontic patient: airway issues, joint issues, sometimes upper cervical instability, hypermobilities, tongue ties, all that. You as an orthodontist have to understand all of it and be able to navigate what do you do about it. And that's really where I feel like you can really choose your path in orthodontics. You can be a functionally focused type of orthodontist that really looks under the surface, or you can obviously limit to what you like to do. And if you love straightening teeth and all of that, go for it. But ultimately, we as orthodontists have a unique skill. We know how we learn in residency how to move teeth. No other residency really learns that to the same level that we do. We also learn how to set up plans for patients to have orthodontic surgery or TMJ surgery. We know how to set these up. We just have to know when to apply it and what patient fits this exact type of category. And ultimately, again, I use this analogy, but we have to know where to land the plane. We know how to move teeth. We can make them look pretty, but we have to know not just where to, how to get the teeth to fit together, but how to have the teeth fit together in a way that supports everything else, from the joints to the neck to the airway to the breathing. And also for tongue ties and restrictions, we have to incorporate all of that into our treatment plan, or else we might leave the back door open to something that's going to undo our orthodontics, our result. So back to your question or your thought, which is that you can choose your path. Yes, you can. But ultimately, I think all roads lead to, we have to understand all pieces of this patient, and we have to have the right tools to help us make decisions, which are the CBCT, MRIs, and other studies that help us understand why that patient's in our chair.
Yeah, and I want to go back to the origin of where this all came from. It's from, looking at images and making decisions about patients. And I know there's a big missing piece in dentistry, and you're actually developing a course on how to read images. Talk about the challenge in understanding how to read an image, understand an image, because I think we could all agree. You put 5 orthodontists in front of one image, they may not all see the same thing. True?
Yes and no. I think if we're looking in 3D, it's black and white right there in front of us. That's why I love imaging, is that, that 3D image tells the truth of the patient. Now, talking about how did that patient get to what happened on that screen in front of us, that's where the 5 of us will disagree or have different thoughts. And, I totally agree with that part. But ultimately, the imaging part of things is the common denominator, I feel like, that allows us to at least see the same thing. And if we have different treatment plans to address what we see, or if we have a different conclusion as to why that patient is that way, then at least that's us as doctors. We have our own ways of which works better in our hands. But the imaging at least sheds light on what's really happening under the surface. And then we can make our clinical decisions from there.
Yeah. So you get a chance to work with a lot of dentists, not just orthodontists. When it comes to the question of overtreating your patient, where do most people go wrong? Let's speak to the overtreatment piece. Like, what would you consider overtreating from your perspective?
I think an overtreatment would stem from not doing enough diagnosis and yet doing something that you felt or that applied your tools in the way that they shouldn't be. So an example of that would be, let's diagnose on just a pano as an orthodontist and design an orthodontic treatment plan. Absolutely, that is something you should be concerned about. But if we are utilizing the tools that are in front of us with today's technologies in terms of, like I said, 3D imaging, treatment simulation outcomes, then what we're really designing our treatment for is to be able to execute the plan that fits that patient in front of us. And I think back to what people are considering over treatment by expanding early on kids, or by especially looking at jaw joints and doing joint directed types of either supportive therapies with splint therapy, or also all the way to surgical therapies. That's where a lot of the stones get thrown, because people may not understand the diagnostics that got us to those conclusions. And so back to the course that you brought up, one of the biggest questions I get is, patients or doctors will come up to me after I've done a presentation and they go, I never learned in school how to read a CBCT. I especially never learned how to read an MRI. And I think that when we are not introduced to these concepts and don't have a good matrix for what we're looking at or how to look at it, I think it scares a lot of people. Yeah. And ultimately, back to where we're trying to go is let's create a common imaging set that really unifies what should we be looking at as orthodontists. So in my workup for every patient, and I know I talk with a lot of other orthos that do similar, but I have a whole section on the patient's airway, specifically their nose. The back of their airway, the pharyngeal airway, that'll change from image to image, moment to moment. That one is not as reliable off of an image. That's where you need sleep screening or sleep studies to really help us understand that part of the airway. But you can see the nose clear as day on these CBCTs. And if a patient has a narrow nasal base or enlarged turbinates, huge adenoids, tonsils, and on your clinical exam, you're asking, how does this patient sleep? How do they breathe? And their parents are saying not well. These are findings that correlate to each other, and we can really help. And again, the imaging is what's showing us what's under the surface, at least from an anatomical standpoint. The sleep studies help us understand behaviors. We have to bring all these things together to make our plan. And so back to other things, that you mentioned, the other sections I have on all my workups are the joints. And I can't say this enough, kids hurt their jaw joints early in life, and it screws up their jaw growth. There's an article by 1993, Kurt Schellhaus and Clyde Wilkes did a great study looking at how common it is for kids to have TMJ disc displacement. In this study, there were kids 14 and younger, and it was astounding how many kids that came in for an orthodontic evaluation had confirmed disc displacement on their MRIs. Absolutely terrifying. And for us as orthodontists, we have to know how to deal with that. That's what's scary is when you're not taught how to deal with a displaced disc in traditional orthodontic setting. And that's really what I've made my focus is, not only identifying it, but making protocols as to when we see this type of disc displacement. If it reduces, we need to do certain things. If it doesn't reduce, we're in a much different category. And so that's, back to the controversy of this that I want to bring up, that JADA article that came out. It was essentially saying, and what kills me is that if you do an MRI on a patient and it shows a disc is displaced or that it's not, that it shouldn't change what you do. You should just do splint therapy and never look at doing any type of surgical or any other type of treatment because that MRI really didn't matter. That's essentially what this article argued was the MRI is overtreating the patient because it doesn't matter towards treatment planning. And ultimately, I say no to that. That is that because it changes absolutely what you do to treat this patient. For instance, if a young kid, and we know this from research, this is a very nice paper done back in 2019, that if a young kid gets back underneath of the disc in a predictable way, they grow again. Their condyles grow, which means for us as orthodontics, their mandible grows forward. They are able to help correct the class 2 via growth, not just movement of teeth. If the patient doesn't get back underneath the disc, they don't grow well. We know that from literature too. And that's really where, again, if we do our diagnostics and we see that an MRI shows that the patient is completely off the disc, that changes what you do orthodontically. I am not expecting that patient to grow. If I try and put that patient in a Herbst or a mandibular advancement device, I might make them way worse and great symptoms. And that's where what kills me is that 99% of the patients that are adults that I see now who have severe TMJ issues, they had multiple rounds of orthodontics. They wore headgear. They wore Herbst. They wore rubber bands. They were in treatment 4 to 5 years because essentially the orthodontics was battling a joint issue under the surface that no one knew about. And the traditional things we were taught in ortho to try and fix an overbite or the lower jaw being back just made it worse because they loaded a joint that could not handle it. So from an orthodontic standpoint, again, the MRI and the imaging dictates treatment. And we have to feel comfortable in the uncomfortable, which is the MRI world and the CBCT world. And that's why I'm so passionate about helping people, learn how to read these images, because it is something that we have to learn going forward as a profession. I'd say this every time. Right now, ortho seems to be dumbing itself down to just teeth. And if all we are is teeth movers, then all of the at-home aligner companies will do the same thing for much cheaper and probably better than us as orthodontists. Sometimes whenever the algorithms they have are the same ones we do. So we have to be better. We have to do better. We have to diagnose better. And that's really what I come back to as an orthodontist, is these things are in front of us, whether we like it or not. We have to be able to diagnose and know how to handle it from a treatment planning standpoint. Otherwise, we put our patients at risk.
Yeah, Drew, amazing, buddy. You got to keep banging that drum and being who you are. And I'm going to tell you guys, as listeners, you have to check out his stuff. If you haven't seen Drew speak, you got to see it. To this day, we probably have over 1,000 clinical videos in ActU. The single largest requested video series that we have is from Drew. And if you email me at kirk@actdental.com, I'll send you both of them. And I always get a thank you back from whoever it is. They're like, wow, that was incredible. I just think you're one of the most gifted thinkers. And you should embrace the fact that not everybody's going to love what you're thinking about. So that's totally cool, too. And so I can't thank you enough. I want you to give us, obviously, I want you to tell people where to go to consume more. I want you to talk about your study club. I want you to talk about where they might find this MIR virtual course once you finish it. But before you do, give us some final thoughts on, am I over-treating my patient?
Yeah, so just to wrap up this entire thing on over-treatment, I feel like we as orthodontists should feel comfortable treating at bigger level than just teeth. We know research supports us now in terms of the airway interventions, the TMJ interventions, that if we diagnose well, which again does take a higher level of diagnosis, we are looking at CBCT as the baseline, MRIs if indicated, if there's a jaw joint injury, sleep screening, sleep studies. We have, if we are diagnosing at this level, we have to have answers for the patient too, as to what do we do about it. So we got to start getting comfortable in the uncomfortable. I know I said that earlier. But ultimately, we are not over-treating if there is an issue in front of us. Every CBCT I have is read by a radiologist, and they comment on these things. If I don't have an answer for what do we do for that anatomical problem, then yeah, I haven't done my job. And a lot of that is what spurred me to think this way, is that I have to know these big picture things. I can't just be a tooth orthodontist. I have to be a foundational orthodontist, because this is growth, this is development, this is pain in some cases, and we have to know how to take care of it. It is our world as orthodontists, whether we like it or not. So we are not treating if we are diagnosing thoroughly and if we are making clinical decisions that affect the health of our patient as soon as we see them. In any other part of medicine, we don't wait until end stage to take care of something if we could have done something before. Why are we as dentists relegated to be so hands off until it's end stage, and then we have to do huge surgeries like total joint replacements, which I'm not saying is bad at all. I have many patients that have to do that I interact with Dr. Shaw. He's an amazing surgeon. I have to fix the bite and get the bite ready for him to do his job. That patient should have never gotten there. That is my biggest thing I wanted to take home from this, is that patients do not have to get to end stage if we are diagnosing and treating early, and it is not over-treatment to treat kids when we see the problem, whether it's joints, airway, bigger things than teeth. It is our entire world as orthodontists to do this.
So well said, brother. So I want you to point people where to go if you're listening to this podcast and you want to learn more about Dr. Drew McDonald. Where can I go? And I'll even say this. If you have a patient that you care about and you want it done right, you can even send them to Drew. And I think you even mentioned there's been patients that have come from this, like they've searched for solutions orthodontically everywhere and somehow end up in your practice. And that's really not the purpose of this podcast, but I'm just telling you, like, if you're looking for an answer, this is your guy. So Drew, where do I go to find out more about you? Like, how do I follow you? Where are you at?
Yeah, so a couple upcoming projects should be done by the end of 2024, but I am putting out a virtual series of how to read an MRI. Again, I know this is a not taught skill in any of our orthodontic or even dental, at least at this level, and I want to make it accessible. So, it'll be me going through, what's normal, what's not. how do you actually look at these images? Because if the first time I looked at an MRI, it was like an ink blot. I didn't know what I was looking at, what did it even mean? And so I want to simplify that down to help people be able to see that. So the second is, what do you do with this? That's an entirely different course meant for orthodontists that will live on online as well. But basically, now that I know how to read an MRI, now that I've taken an MRI and seen what's going on with my patient, how do I apply this? What do I do differently now for my patient? And so both of those will live on, it'll be actually my practice website, which is orthobymcdonald.com. And so keep an eye out on the website for, basically updates as to when those are released, but it should be by the end of 2024. Chicago Study Club, I'll shift gears. I love working with Jim McKee, Seth Atkins, Kurt Ringhofer, all guests on your show and good dudes. But this is really where we dive into much more of a restorative dentistry focus of the jaw joints, the airway. We're really pushing the envelope on technology too. Our last meeting that we had was amazing. We had hands-on of, now that we've diagnosed this joint issue, what does it mean for your restorative? How do you 3D print an onlay to support that joint? How do you 3D print a splint that was reflective of what the MRI told us? And so we are really merging all of this together in a study club format. And it's the best study club it is a great, a very cohesive group that's been together, people at a very high level pushing each other every time. And so that's a great study club. I love working with those guys. We have our next meetings coming up, but you'll see the links for people that are looking to join. We welcome everybody, and it's, but you got to have an interest in the joints here, because that's a big focus. But if you want to learn and really progress, that's the best place. And again, I come at it from the orthodontic standpoint of how to diagnose joints on kids, how to apply this to orthodontics. But really, if you're a restorative dentist, this is the best place to learn and apply and learn how to do this at a high level every day in your practice.
Yeah, totally agree, brother. Thank you so much for all that you do. And Drew's going to be back again and again and again. He always brings some great learning, some controversial topics, just to help you create a better practice, better life. If you're not taking notes for the podcast, this is how it works. We are taking notes for you. So if you flip up to the notes in Stitcher, iTunes, Spotify, Amazon, you're going to see links to everything Drew mentioned, and you can just click on them and follow there. I'm going to highly encourage that you do. And if you have a study club and you have not had Drew speak, you are missing out, because he will push the envelope and create an amazing presentation and some great dialogue for you guys. You'll absolutely love it. So, Drew, thank you so much, brother. Stick around while we say goodbye to everybody else. But thank you guys for listening to the Best Practices Show podcast. The goal of this podcast is to bring you the best thinkers with the best information to help you create a better practice and a better life. And you keep showing up, we're going to keep bringing it. So we're so grateful. So keep sending us suggestions for things you guys want to see. You can even send me suggestions that you want to hear Drew talk about, and I'll make Drew talk about them. And we'll do it over and over again. So until we see you guys next time, or you hear from us next time, keep watching or keep listening to the Best Practices Show. You guys enjoy your day.